Okay, I think we'll go ahead and get started. So I want to say hello and welcome. So happy to have you all here. Welcome to the webinar of Management of Brain Metastasis. I'm Leanne Kramer. I'm a patient advocate. Before the presentation begins, I'd like to tell you a little bit more about SHARE. SHARE is a nonprofit organization that has been helping people through breast, metastatic breast, ovarian, and uterine cancer for the last 45 years by offering support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, you can visit our website at sharecancersupport.org. So all participants will be muted during the presentation. When the presenters finish presenting, we'll have a Q&A discussion. You are welcome to submit questions during the presentation through the Q&A section. It's at the bottom of your screen. The chat section will be disabled. When asking questions, remember that the presenters are unable to give specific medical advice. So please keep your questions general in nature. The webinar is being recorded and will be available on the SHARE website soon. Now I'd like to introduce our speakers. Dr. Aixa Soyano is an assistant member in the Department of Breast Oncology at the H. Lee Moffitt Cancer Center and an assistant professor at the University of South Florida Morsani College of Medicine. Dr. Soyano is originally from Venezuela and received her MD degree from the Luis Reziti School of Medicine at the Central University of Venezuela in 2008. She moved to the United States in 2012 and completed an internal medicine residency at Stewart St. Elizabeth's Medical Center in Boston, Massachusetts. Dr. Soyano subsequently completed a hematology oncology fellowship at Mayo Clinic in Jacksonville, Florida in August 2018. She then joined Moffitt Cancer Center to focus on breast cancer treatment and research. Dr. Soyano is interested in the multidisciplinary care of patients with breast cancer of different age groups, ethnicities, stages, and subtypes. Her research interest is in the future of oncology related to personalized medicine. And then we also have Dr. Kamran Ahmed. He's an assistant member of the Department of Radiation Oncology and Department of Immunology at Moffitt Cancer Center. He is also an assistant professor in the Department of Oncologic Sciences at the University of South Florida. Dr. Ahmed received his medical degree from the Mayo Clinic School of Medicine in Rochester, Minnesota, and completed an internship at Baylor College of Medicine before completing his radiation oncology residency at Moffitt Cancer Center. Dr. Ahmed's clinical focus is on the management of breast cancer. Dr. Ahmed's primary research interest is in studying the synergy between combinations of immunologic and targeted agents with radiation therapy to improve clinical outcomes. He is the principal investigator of several multi-center clinical trials in the management of advanced disease presentations and brain metastasis with novel therapeutic and radiation therapy. And with that, I am going to turn it over to our speakers.
Great. Thank you so much for having us. I'd like to thank the organizers and SHARE and for the invitation to speak on brain metastasis. So I'll share my screen. As was mentioned, I'm a radiation oncologist at Moffitt Cancer Center. I have a clinical and research interest in the study of breast cancer brain metastases. So I'm going to be speaking first and giving information about the local therapies for brain metastasis, and then I'm going to turn it over to my colleague, Dr. Soyano, who's going to talk more about the medical management of brain metastasis. These are my disclosures. So how do brain metastases develop? So it's believed that all brain metastases initially develop from the primary tumor site, So the most common primary tumors that develop brain metastasis include breast cancer, lung cancer, and melanoma. So from the primary tumor, it's believed that cells then enter the bloodstream and then can get arrested in the capillary beds of the blood-brain barrier. And then from here, slowly these tumor cells can enter the brain vasculature with the assistance of certain genes and proteins. So what are the risk factors for the development of brain metastasis from breast cancer? So it's believed that advanced stage at diagnosis, certain breast cancer subtypes, such as HER2 positive over triple negative, may preferentially develop brain metastasis. And then also patients who have the BRCA1/2 gene mutations may also be at higher risk for the development of brain metastasis. There's other clinical factors that may also contribute to an increased risk. This includes a younger age, the development of pulmonary or lung metastasis, and then also African American ancestry. So because of the blood-brain barrier, which limits the ability of traditional chemotherapeutics and targeted agents from entering the brain, local treatments have really been keys to the management of brain metastasis. So for patients who have more isolated brain metastasis, potentially patients who are symptomatic from a larger brain metastasis, surgery is oftentimes recommended for removal of that brain metastasis and then also for potential diagnoses as well. This is oftentimes followed by radiation treatment to the tumor cavity. And then for patients who also have a few additional lesions that are otherwise identifiable by MRI, stereotactic radiation treatment or focal radiation treatment is oftentimes recommended. For patients who have more diffuse brain metastasis, this doesn't necessarily mean 5, but certainly patients who have more than 15 brain metastasis, oftentimes whole brain radiation treatment is recommended over stereotactic radiation treatment because in addition to the lesions that we might be able to identify on an MRI, there may also be micrometastatic deposits that could lead to better outcomes with the treatment of whole brain radiation treatment. So how does radiation treatment work to kill cancer cells? So it's believed that cell killing occurs from ionizing radiation treatment by causing DNA damage. This can lead to chromosomal damage, such as dicentric formations, ring formations of chromosomes that preferentially have the ability to kill cancer cells while allowing normal cells to regenerate. So the radiation treatment planning process is generally the same for most patients. It involves a process similar to what's diagrammed here. Initially, all patients will undergo a simulation scan. Now, this could be done either with a CT or with an MRI. And then from this scan, the radiation oncologist plans out the delivery of the radiation treatment. This planning process can take a few days to a couple of weeks, depending on how complicated of a radiation treatment plan is being created. There's always a verification process that then takes place from the planning stage to make sure that what has been designed by the radiation oncologist alongside their radiation treatment planners and the physics team can actually be delivered on the machine. And then obviously the end goal is to then help patients by developing a radiation treatment plan that can then be delivered to a patient. So I mentioned the two different approaches that we use in terms of radiation treatment to treat brain metastasis. So this can include whole brain radiation treatment, which is diagrammed here. You can see that over here you have radiation dose that's going throughout the brain. This is typically delivered between over 1 to 2 weeks. And generally these are lower doses than what we're using when treating with stereotactic radiation radiation treatment. Stereotactic radiation treatment is a higher dose radiation treatment that's just focused in on the tumor that we can identify on an MRI. And this is delivered typically over 1 day, but for larger brain metastasis or following surgery, this may be delivered between over 3 to 5 days. So what are the side effects of brain radiation treatment? So every patient is a little bit different, but generally for all patients, we like to tell them about what they could anticipate during treatment. So in the short term, this could include fatigue. It could include scalp irritation or hair loss, which may or may not be permanent. There might be nausea or vomiting, headaches, as well as muffled hearing. It's important to note that a lot of these side effects can be managed fairly easily by with your radiation oncologist if you have these side effects at all. Long-term side effects from radiation treatment include short-term memory loss. So this is particularly the case sometimes with whole brain radiation treatment. And I'm going to go over in the next couple slides how we've now have management techniques for this. And then potentially also damage to normal tissue, but that's a rare side effect of radiation treatment. So one of the reasons why we like to use stereotactic radiation treatment over whole brain radiation treatment is because of the potential for short-term memory loss that can occur from whole brain radiation treatment. Now, there have also been studies that have looked at different techniques to minimize that side effect from the radiation treatment. So one of these techniques is to avoid treating the hippocampus during the delivery of the whole brain radiation treatment. So you can see what basically that looks like, but the hippocampus, which is located in the temporal lobe of the brain, has important functions in the development of memory. And by avoiding those doses of radiation treatment there, we can, studies have shown that we can decrease the effect on executive function and memory. In addition to that, we oftentimes will prescribe Memantine, which is a GABA receptor antagonist, which is oftentimes given to patients who have dementia, but delivering this alongside the radiation treatment during and then up to 6 months afterwards has also been shown to be beneficial in reducing the effects to memory from whole brain radiation treatment. So I talked a little bit about surgery as an option for those patients that have isolated or larger brain metastasis that have symptoms. There's been a few important studies that have come out which have shown us that delivering radiation treatment to the tumor cavity following surgery is really now the standard. So this includes one phase 3 study which showed that there was improved cognitive function with the delivery of SRS compared to whole brain radiation treatment, which is what we used to do years ago. And then another phase 3 study has also revealed that this reduces the risk of local recurrence in patients that have 1 to 3 surgically removed brain metastasis compared to observation. So oftentimes after surgery for brain metastasis, radiation treatment is recommended, and that's really kind of the standard of care now. So what is the impact of standard brain metastasis management? So these are just kind of rough numbers to kind of, and that have been shown from a large database of patients to help predict overall outcomes in patients that have brain metastasis. Those factors were found to be performance status, breast cancer subtype, age. So in patients who are potentially older may have a worse outcome or more brain metastasis as well too. And there's a large range of survival that was found in this study with a range between 3 to 26 months. It's important to note that this is an older study. This was published in 2015, and since that time there's been a lot of new improvements in the management of brain metastasis, both in radiation treatment and in systemic management. But I think some of these factors still go into play in determining overall prognosis. One of the ways that we've learned we might be able to get over the barrier of the that limits our ability to combine systemic therapy in patients with brain metastasis is potentially delivery of radiation treatment in the window of about 1 month between the delivery of a systemic therapy. So there's been a couple of studies that have shown that potentially if we can sequence the radiation treatment with the delivery of a drug, we might have a certain window in which we can potentially limit the role of the blood-brain barrier in inhibiting the entry of a systemic agent and then allowing that agent to potentially act in the brain. And so because of that, there's been a couple of studies that we've opened at Moffitt Cancer Center to help study this and to see whether or not we can potentially take advantage of that. So immunotherapy has had a large role in the management of other cancers, melanoma, non-small cell lung cancer, and now also has an increasing role in the management of breast cancer as well too. But this is one drug that has been shown to be beneficial in potentially the management of brain metastasis from melanoma. So we were interested in looking at this in the setting of breast cancer brain metastasis to see if there's potentially a window that we could use to deliver the immunotherapy with the radiation treatment to allow for an improved outcome. So this was a small study that we did. It was of 12 patients. We found that the treatment was safe, and potentially this might be an option for triple negative patients, and we're going to be continuing to study this at Moffitt Cancer Center in an upcoming trial. And I just wanted to briefly touch on leptomeningeal disease and a potential treatment that we have for patients with this type of cancer as well. So leptomeningeal disease is a more advanced form of central nervous system metastasis. It's believed to then involve the lining of the brain and then also of the fluid that surrounds the brain and the spinal cord. For patients who have HER2 positive leptomeningeal disease, it's been shown that potentially if we can deliver HER2 targeted therapy directly into the cerebrospinal fluid through an Ommaya reservoir, we might be able to lead to improved outcomes. So this was a study that was published in 2018, which showed us that using intrathecal Herceptin with the delivery through an Ommaya reservoir may have benefit for patients that have HER2 positive disease. And now at Moffitt Cancer Center, we have opened a subsequent trial where we're delivering intrathecal Herceptin alongside intrathecal pertuzumab as well too for patients that have HER2 positive leptomeningeal disease. Radiation treatment plays a large role in patients with leptomeningeal disease by palliating symptoms. And so patients receive that before they start the delivery of the intrathecal Herceptin and Perjeta. So this is a study that we have open at Moffitt Cancer Center as well too for patients that have HER2 positive leptomeningeal disease. And now I'll turn it over to my colleague, Dr. Soyano.
Thank you, Kamran. So thanks for having me today, and I'm gonna talk to you guys a little bit about the systemic therapies for breast cancer brain metastases. So before we talk about that, we have to know that not all breast cancers are the same. Not all breast cancers are developed or found because of the same cancer markers. So in all breast cancer, we tend to divide them into different subtypes. And those subtypes are based on the 3 main receptors that we can find in breast cancers, which are the estrogen receptor, progesterone receptor, and the HER2 receptor. So when either the estrogen or the progesterone is overexpressed in breast cancer, we call that hormone-positive breast cancer. And what that means is that the breast cancer cells are feeding off of the hormones, estrogen or progesterone that's around in our bodies. So they use them as a food or fuel to live. The HER2 receptor is a different receptor that when it's overexpressed, it just allows the breast cancer cells to grow rapidly. So the most common subtype of breast cancer in the US is that hormone-positive HER2-negative breast cancer, as you can see here on the chart, and represents about 70% of those breast cancer cases. The other third is represented between the triple negative and the hormone positive. And there's also a different molecular subtyping. It's called luminal A, B, basal-like, and HER2. There's a lot of overlap, but it tells us mainly that for those hormone positives, there are ones that have a little bit more of a better prognosis and responsiveness to hormonal treatments, and other ones that are less responsive to hormonal treatments, but responsive to chemotherapy. So it allows us to kind of determine what's the right treatment for each subtype of breast cancer. So back to breast cancer, brain metastasis. So how common is it? We know that as patients are living longer, and breast cancer is a second most common cancer in the US in females after skin cancers. We know that these patients are living longer and we're detecting it earlier. So the incidence of breast cancer brain metastasis seems to be going up as well. This was a meta-analysis. It means a collection of other trials that was published this year that showed that the incidence of brain metastases at or following the diagnosis of metastatic breast cancer ranges between 25 and 46%. So somewhere along the 20 to 40% of breast cancer patients that have metastases will develop a metastasis to their brain. We also know that the hormone-positive HER2-negative was the most common subtype of breast cancer found in early stage, but this is not true for breast cancer brain metastases. In brain metastases that's coming from breast cancer, the most common ones are the HER2-positive and the triple negatives, and that represents a little bit over a third of those, and then only about 15% of the breast cancer brain metastases are hormone-positive HER2-negative. Here at our institution, we did an analysis, so a retrospective review of all the brain metastases that were found in our database of breast cancer, lung cancer, melanoma. And we found that because there's no real screening national guidelines about looking for this metastasis in breast cancer patients, that the patients that had breast cancer were more likely to be younger, present with more advanced central nervous system disease, require whole brain radiation, and have poorer overall survival in general compared to the lung cancer patients and the melanoma patients. So it's food for thought about, modifying and trying to find this patients earlier so that their outcome can be improved in the future. But why is it so challenging to treat, and how is it that it's so common? So Dr. Ahmed already talked a little bit about the blood-brain barrier. So we know that it is, what is it? It's a network of vessels and tissue that keeps the space very close so that harmful substances cannot penetrate the brain, because the brain is our most vital organ. So we don't want any harmful substances or toxins or bacteria or viruses to get into that space. So it's a very, very well connected and defined tissue collection that allows that normal substances such as water and sugar and carbon dioxide, things that our cells need to pass by, but any bigger substances like bacteria or drugs do not penetrate there and cause more harm. However, in patients that have brain metastases, as we mentioned before, sometimes when we do radiation, we kind of open a space into that blood-brain barrier, and some of those drugs can actually penetrate that space, and that will help the brain metastasis treatment. So hormone-positive HER2-negative breast cancer, as we said, is the most common subtype of breast cancer. It tends to be more indolent, and the patients tend to have a longer life expectancy compared to the triple negative of the hormone positives. Common sites of metastases include the bones, the lungs, and the liver. And initial treatment options include endocrine therapy, which we call hormone blockers, plus or minus targeted therapy, which could be CDK4/6 inhibitors or mTOR inhibitors. These are inhibitors of particular areas of the cell cycle that allow them to divide. So that if we are inhibiting or blocking that the division of the cells, and the cells get arrested and then they cannot further progress. Some common CDK4/6 inhibitors are the ones listed here: Ibrance or palbociclib, Verzenio or abemaciclib, and Kisqali or ribociclib. Why is that important? Because we know that CDK4/6 inhibitors, especially palbociclib and abemaciclib, have shown some intracranial activity in small early phase trials. So it gives us an idea that these drugs potentially can penetrate that blood-brain barrier and help treat, in combination with the local regional therapies, the brain metastases. There was also a phase 2 trial of hormone-positive metastatic patients with active brain metastases that showed modest clinical benefit in this patient. So this is a small trial, and even though they did not meet what we call their primary endpoint, it included a variety of patients. So it included patients that were not resectable, meaning they couldn't go to surgery, patients that had the more advanced CNS disease called leptomeningeal disease, and patients that were actually planning to have surgery. But importantly, the blood studies that from the patients from this trial showed that there were adequate concentrations of the drug abemaciclib in their brain metastases that suggest that there was a good penetrance of this drug. So that led us to study that here at Moffitt Cancer Center, Dr. Ahmed being the PI. So we have a phase 1/2 study of stereotactic radiation, or SRS, and abemaciclib in the management of these patients that are hormone positive, HER2 negative with brain metastases. So this trial allows patients that are eligible for SRS that have up to 15 brain mets, and they will give them abemaciclib along with their radiation, and they will continue their abemaciclib and endocrine therapy, and we will examine what's the follow-up and their response. So here I listed some clinical trials specifically for hormone-positive HER2-negative breast cancer. So the first line I highlighted there with the star is a trial that we just talked about, and it's open here at the Moffitt Cancer Center. But additionally, at Emory University in Atlanta, there's a similar study using stereotactic radiosurgery with abemaciclib, ribociclib, or palbociclib in treating this patient. So another investigator is looking at that same concept. So hopefully we'll have more data so we can, change practice for the future. A different subtype of breast cancer is called triple negative. And what that means is it lacks expression of estrogen, progesterone, or the HER2 receptor. These cancers tend to be more aggressive and are associated with genetic mutations or predispositions such as BRCA mutations, PALB2 mutations, among others. And these patients are commonly treated with chemotherapy plus or minus a combination with immunotherapy. The most common site of metastases are liver, lung, and brain. And because we treat these patients commonly with chemotherapy, we know from experience that some chemotherapy agents penetrate the blood-brain barrier to some degree. And as I mentioned before, there's probably more permeability after local treatments, allowing more of these drugs to penetrate that space. Some of these drugs are the fluorouracil derivatives, such as capecitabine or Xeloda, some platinum salts, so carboplatin, cisplatin, and some anthracyclines, such as doxorubicin, which we all know as the red devil, unfortunately. In addition, there was a recent approval last year in April by the FDA. So it's an antibody drug conjugate called sacituzumab govitecan. The brand name is Trodelvy. So an antibody drug conjugate, it's an antibody that goes and targets a specific protein present in cancer cells. For this particular drug, the protein is called TROP2. And that antibody is linked to a small chemotherapy drug. That drug is called SN38. So when the medication is administered, so it's an IV medication and it's administered, it goes, it targets the TROP2 proteins in the breast cancer cells and delivers the chemotherapy SN38 directly into the cells. And that inhibits the repair of DNA and leads to cell death. This was based on results from a trial called the EMU-132 trial. That led to the approval by the FDA. But there was another trial called the ASCENT-3 that showed that in some patients that had breast cancer brain metastases, there was an improvement in the progression-free survival or the time to progression in patients that had stable brain metastases from their tumors. So that led to follow-up studies that we'll talk about later about possible clinical trials. Another type of breast cancer is called the HER2-positive breast cancer, and that's characterized by overexpression of the human epidermal receptor 2. We call that HER2. So in a normal breast cancer cell, if they have a normal amount of HER2 receptors, that sends some signals telling the cells to grow and divide. But if this is overexpressed, then there's too much HER2 signaling, and then the cells keep growing and growing and growing. This was considered a very aggressive, or is considered an aggressive type of breast cancer. However, breakthrough research in this subtype has completely changed prognosis to good. And there has been multiple new treatments approved in the past 5 years, and some have blood-brain barrier penetrance. So this is just a little bit of a timeline to see how advanced the research has gone in this subtype of breast cancer. So it was in 1984 where the HER2 gene was initially identified, and in 1985, gene amplification was found in breast cancer cells. So it took a few years to develop this drug, this monoclonal antibody called Herceptin, that was developed in 92, and then in 98, it was approved for the treatment of metastatic HER2-positive breast cancers. And in 2005, it was shown that it improved the life of early HER2-positive breast cancers. Then it took a few years, but another drug called lapatinib also was approved for the treatment of metastatic HER2-positive breast cancer. And then after that, it was just an explosion of treatment options for this patient. So in 2012, we got the approval for pertuzumab, another monoclonal antibody that targets the HER2 proteins. In 2013, TDM1, another antibody drug conjugate that targets the same protein. And then just in the past 2 or 3 years, we've gotten multiple indications and multiple treatment options for this patient. So more to come in this subtype of breast cancer. So trastuzumab and tamsuline TDM1, or the brand name Kadcyla, it's an antibody drug conjugate. So as we said, it's an antibody that targets the HER2 protein, but then it delivers a small chemotherapy payload to the cells. It was approved in 2013 by the FDA for the treatment of metastatic HER2-positive breast cancer based on the Amelia trial. That's listed down below. So that particular trial randomized patients, so it divided patients to receive the TDM1 versus lapatinib, which is another HER2 drug in combination with capecitabine, which is a chemotherapy drug, and that was a standard of care at that time. And this particular trial showed that there was improvement in the survival of these patients and then the time to progression for these patients. And this is also used in early breast cancer recently. But this Amelia trial, a few years later, the investigators went back and they looked at, of the almost 1,000 patients that were enrolled in this trial, they looked for patients that already had a history of stable brain metastases, and they saw they had about 50 patients in each arm. And they noted that the patients that received TDM1 actually had an improvement in their survival. So they were living longer by receiving TDM1 than capecitabine and lapatinib. So that translates into there's possible CNS activity of these drugs into the brain metastases. HER2CLIMB was another trial that compared the use of tucatinib, which is an oral drug that blocks various sites of the HER2 family of proteins, plus capecitabine, which is a chemotherapy drug, plus Herceptin, in comparison to Herceptin, capecitabine, and placebo. This had a pivotal trial design in the sense that this particular trial allowed patients that had active brain metastases to be enrolled and receive the experimental treatment. When we look at clinical trials in general, most patients that have active or progressing brain metastases sometimes are excluded from the trials. So this particular trial allowed patients to participate. So of the total 612 patients, 291 had brain metastases, so 48% of the population had brain metastases. 40% of those had stable brain mets, whether they had treated, they didn't need any new treatment, and then 60% had active brain metastases. So some of them, 20% were just diagnosed with newly brain mets, and then some of them had a diagnosis of brain metastases, but were treated, were progressing, and then they received experimental drug. So if we look at the graphic on the left, we know that the combination of the tucatinib, trastuzumab, and capecitabine reduced the risk of disease progression or death in patients with brain metastases by about 52%. And then if we look at the graph on the right, we know that of the whole patients, when they studied them, all the patients that received the tucatinib not only had an improvement in disease progression, but it also reduced the risk of developing future brain lesions or even death. So this had completely changed the way we see HER2 brain cancer, breast cancer brain metastases, because we know that we have drugs that actually can penetrate that space and can benefit patients to help live longer, let them live longer. Another antibody drug conjugate that was approved in 2020 was Enhertu or FAM trastuzumab deruxtecan. This was approved after a phase 2 trial called the Destiny Breast 01. This is a treatment that's approved for metastatic breast cancer patients. And what they did is they also looked back at the patients that have had brain metastases, and they looked at how they did. So they note that of the, this is a smaller trial, it was a phase 2 trial, but 24 patients had history of central nervous system disease, typically stable. They did not allow patients with active or new brain metastases. But they saw that out of the 24, they had 7 or 40% of those patients. You can see the graph on the right where the columns are going down. So gray or blue means that they were having stable disease or partial response to the treatment with the Enhertu. So this is also being recently proven to be beneficial in patients in the earlier setting, so metastatic, but with just a few lines of treatment. In this particular trial, patients were heavily pretreated. So there's more to come, and this is being studied in patients with brain metastases only, as we'll see. Other oral combinations that we sometimes consider in HER2-positive breast cancer patients that have brain mets is the combination of capecitabine, the chemotherapy drug, plus neratinib or lapatinib, which are oral drugs that target the HER2 proteins. And they have also shown to be beneficial in this particular subtype of patients. So some clinical trials in triple negative and HER2 positive brain metastases, I listed them here. So on the first one is that drug, the antibody drug conjugate, Trodelvy, that's being used in HER2 negative breast cancer with brain metastases. It's a phase 2 trial, and it's across the USA. Available. So it's just about a matter of looking what sites are open and see if a patient might participate. Another trial, a phase 1b/2 trial called Topaz. So it's looking at tucatinib in combination with pembrolizumab, which is an immunotherapy drug, and trastuzumab, so the traditional Herceptin, in HER2-positive breast cancer brain metastases. And that's in Cedars-Sinai Medical Center in LA. There's another trial based off the NIH looking at TDM1 alone versus TDM1 and chemotherapy drug called temozolomide in secondary prevention of HER2-positive breast cancer brain metastases. There's another experimental drug called GDC0084, and that's available at Dana-Farber for patients with HER2-positive breast cancer, brain metastases. There is another mechanism of escape of the or resistance of this treatment that is through the HER3 protein. And here at Moffitt and at Roswell Park, we are studying the use of vaccines, so vaccines of a type of white blood cell called dendritic cells that will target this HER2, HER3 proteins, and we're going to combine that with pembrolizumab, the immunotherapy drug, for the treatment of brain metastases from triple-negative or HER2-positive breast cancers. So this is a phase 2, is actually open at Roswell Park, and it's about to be opening at Moffitt. That's why I put a star there for reference. The next study is a study of TDXD, so that's the Enhertu that we talked about, and this is being studied in a phase 3 in multiple sites across the United States and internationally for patients who have metastatic HER2-positive breast cancer with or without brain metastases. So again, they're trying to expand to see, if this drug is beneficial in this particular set of patients. And then there's also a study based of City of Hope that is looking at CAR T cells. So it's a type of engineer immunotherapy for patients with recurrent brain or leptomeningeal disease. So in conclusion, breast cancer brain metastasis incidence is increasing due to improved systemic control as well as improved imaging techniques. Multidisciplinary management is important to tackle both the brain and systemically. Stereotactic radiation is the standard of care for localized disease. Whole brain radiation is used for more diffuse brain metastases, and improved outcomes may be achieved with combined local and systemic approaches. So that was our presentation for today. Thanks for joining us, and now we're going to go with some questions.
Hi, thank you so much. That was really nice. Dr. Soyano, you mentioned at the beginning of your presentation that there's really not a guideline. There aren't guidelines for screening for brain metastasis. Can you speak a little bit to why that is like that and what your feelings are, and whether there should be?
Yeah, so we go by the ASCO national guidelines or the NCCN guidelines, and there is really no guidelines for screening, meaning, such as when a patient is diagnosed with metastatic disease, we do scans, systemic scans every, let's say, 3 or 4 months or every 6 months to see what's the benefit of treatment, if the cancer is responding to the treatment or not. But we talk as screening is to when someone is diagnosed, for example, with lung cancer, we know that because there's a really high incidence of possible metastases to the brain, we know that the guidelines recommend a screening MRI or CT of the head. In breast cancer, because the incidence is not as high, it's not really adopted by the national guidelines, but we have found, like in the poster that we presented, that because we don't have those screening guidelines, we sometimes find the patients that have breast cancer to have more advanced disease in their CNS because we detect them once they have symptoms. So we're looking into our own data, and we are going to publish that data recently, and we hope that this gets reconsidered by the national guidelines. I know there are other institutions that sometimes have institutional guidelines where they would say, yes, we're screening all patients with high risk, let's say young patients or HER2 positive or triple negative. So I think it's just looking into what have we seen and what the trend is right now in order for us to modify the guidelines for the future.
Okay. So then it must be symptoms that lead to you looking into whether brain metastasis exists. Can you talk to the symptoms that are present or can be present with brain metastasis as well as leptomeningeal disease, if there's some overlap, or what leads you to then do screening?
Yeah, absolutely. So it's hard in the sense that, we could all have a headache, right? And that not necessarily might mean that someone has metastasis to their brain. There is overlap into the traditional tumors into the brain and the CNS leptomeningeal disease. Typically when I talk or I counsel my patients, I talk to them about, symptoms that are not their usual. So if they had a history of headaches, if they're having a new headache, a different headache, a headache that's associated with other symptoms such as changes in their vision or nausea or vomiting, or the headache wakes them up in the middle of the night, or they wake up with nausea or vomiting, those tend to make me a little bit more suspicious that something might happen in the brain. And I want them to bring that up to my attention so we can do the appropriate workup. Also, when patients have sudden loss of vision or something that's associated with weakness, such as like when patients have a stroke, right? Because it depends on what part of the brain is the tumor located at, and if there's swelling that can cause compression into the other structures that might bring symptoms, that's when, so we can have loss of balance, we can have weakness, we can have difficulty speaking, we can have peripheral or central vision loss. So there's just a range of symptoms that we try to counsel our patients to look for. And then there can be some overlap into leptomeningeal disease, but leptomeningeal disease tends to cause more of a diffuse sudden drop and sudden change in their neurological status. And those symptoms tend to be progressively worsening more rapidly than with a traditional brain tumor. So if someone is having, some back pain, and the back pain suddenly starts feeling, that they have no sensation, or they start having loss of control of their bowel or bladder, then that tends to speak a little bit more about leptomeningeal disease. But some patients can also be asymptomatic. So that's why there is really challenging.
Yeah. Yeah, it is very challenging. I wanted to remind the audience that as we proceed with the Q&A, that you can continue even now to submit questions. And we're going to try to get through as many as submitted. Thankfully, the presentation addressed a lot of them, but we may not be able to get through all of the questions just due to our time constraints. So kind of going to bounce back and forth. So as you mentioned, this question said there are so many more trials for HER2 positive than triple negative or ER positive, especially with triple negative, which makes up almost half of brain mets. Why is this, and how do we encourage researchers to work more on this aggressive subtype and open more trials?
Yeah, I think, that's an excellent question. And I think it's just, the breakthrough of newer therapies have been developed in HER2 positive breast cancer for the past 20 years. So I think that's why there's many more options, because they're in many more trials, because we have so much options. But that doesn't mean that there's no clinical trials looking at triple negative. It just has been a little bit harder to tackle, more recently, but there are many escape mechanisms for the triple negative. And there's, I think it's just a matter of time that new clinical trials pop up in the future for this subtype of breast cancer.
Okay. So when you look at, you mentioned some systemic treatments as you were going through the presentation. Is there such a thing as a best systemic treatment for each subtype of breast cancer for brain metastasis? For example, this is the best for HER2.
Yeah, I don't think it's we have any data right now comparing, each approach to another approach. So there's no good data to say, oh, this is the best treatment. It's a discussion of, their oncologist with the patient and see how patients are tolerating the treatment and their past experience with other drugs. So there's a lot of discussion into why would I choose a regimen over another. But sometimes, even though the best treatment might be this, I know that my patient's not going to tolerate it. So it's also about quality of life, right? And maintaining that quality of life. So there's a lot of thought that we put into it, but we also have to consider all the patient characteristic and that relationship with the patient. So it's about exposure to different drugs.
Gotcha. So once you have treated brain metastasis, especially from a radiation perspective, is there a protocol for monitoring the brain after treatment? And if so, what does that look like?
Yeah, so we order MRIs pretty regularly after the diagnosis of brain metastasis. So usually it's about every 2 to 3 months for the first year. And then potentially if we have good control, then we can space that out a little bit longer. Basically, we don't really like to go beyond maybe 4 or 5 months without having some sort of image that's taken, because the goal then after the detection of brain metastasis, if there are future brain metastases, to catch them early so that they can be treated.
So once you've had brain mets, you will always be monitored for them. Is that what I'm hearing you're saying?
Yeah, so that's certainly, I think, our practice here. Once there is a diagnosis of brain metastasis, that monitoring with MRIs does continue.
Okay. And is there a best imaging tool? You talked about scanning or imaging, looking at the brain after treatment. What imaging tool do you use as considered the best practice?
So the standard would be to do MRIs. So that certainly offers a better resolution than a CT scan would, and allows for the detection of smaller brain metastases that could be treated when they're asymptomatic.
Gotcha. I don't think this is something that was addressed during the presentation, but it's certainly a popular conversation among those who have brain metastasis and get radiation, is that of radiation necrosis. What are the risks for it? And how do you, I know there's some difficulty in distinguishing tumor growth versus radiation necrosis. If you could just speak to that a little, that would be great.
Yeah, so that's a good question. So the factors that can lead to higher risks of radiation necrosis potentially are the treatment of larger brain metastasis, potentially higher doses of radiation treatment as well too, and the treatment of multiple brain metastasis as well. So the question of how we kind of distinguish between radiation necrosis versus pseudoprogression, or radiation treatment changes after patients have received radiation treatment, versus tumor growth in subsequent scans after radiation treatment. That's a very good question. So typically, the reason why we're also ordering these scans at regular interval is to really monitor the changes. So, after radiation treatment, sometimes it's hard just with one scan to tell what exactly is occurring. And certainly if patients are asymptomatic, what our preferred approach would be is just to follow those, because more than likely what's occurring is probably just radiation treatment changes. Now, when symptoms also occur alongside those changes that are occurring on MRI, the radiation oncologist might place patients on steroids. And then really it's kind of dependent on where we treated, kind of a discussion between us, the neurosurgeons, as to whether or not we feel like it might be beneficial to remove that area that's been radiated, because really the only gold standard to determine whether or not it's radiation necrosis versus potential tumor growth would be to remove the tumor. But obviously that carries risks as well too. So it's really a discussion between us, the neurosurgeons, also the radiologists play a large role in this. There's sometimes additional scans that we can get, perfusion MRIs that offer a different level of resolution that can help us kind of answer these questions if that's a concern.
So it sounds like while other imaging exists, like I've heard people talk about MRI, spectroscopy, and that sort of thing, what you're saying is it really best is the best judgment of the clinician over time to kind of watch what the tumor does versus really relying on any kind of imaging tool to say yes or no, this is necrosis.
Correct. Yeah, I think certainly the management strategy we follow over here is when there are cases where we're concerned about one of those events occurring over another is really to discuss those cases in a tumor board setting and to kind of have all the experts kind of weigh in on that on that question.
Gotcha. What about, this always comes up with brain metastasis is prognosis. How do you go about that with, I know it's going to be different for individual patients, but how do you address that?
Yeah, so I think that's an important question. We presented a slide that kind of showed some factors that can contribute to overall prognosis, but I think that's really a discussion that needs to take place on an individual basis with the patient, with the provider, to judge not only the treatment that has taken place of the brain metastasis, but then also their overall systemic treatment, the burden of cancer throughout the whole body as well too, and potential options that are still available for patients. So, I think we've made a lot of strides in the management of brain metastasis to improve outcomes, but I think we have a long way to go.
Agreed. This question came in, do you see mRNA technology coming into play into future therapies for brain metastasis?
I mean, I think it's a broad question because I'm not sure what they're asking, right? It could be, for surveillance or, response to treatment or to detect, residual disease. So a lot of that is still, it's currently being studied. A lot of it might not necessarily be what's available to the general public, when you're enrolling in a trial, but a lot of the current clinical trials are looking into this technology about those who have residual disease. They can detect circulating tumor cells, and how would that play along with their prognosis and evolution of their cancer going forward. So there is a lot that's into play into that. I just don't think that it might be publicly put there because it hasn't, it's still in the research space.
Gotcha. Is there a standard time frame after receiving radiation for recurrence, or is there some kind of, is it different for everyone, or what's the likelihood of recurrence after radiation?
So, we do a pretty good job with treating the areas that we can see when we treat with stereotactic radiation treatment. So overall, the control rates in the areas that we treat are about 90% or so. However, because it's just focused radiation treatment, that, unfortunately the cancer can come back in areas that we don't treat. And that's why we really continue to monitor with MRIs quite regularly, at least, between 2 to 3 months for the first year after receiving stereotactic radiation treatment to monitor for the growth of additional sites of cancer. And it's hard to predict in every patient what that interval would be, but that's why we kind of order those MRIs at pretty regular intervals across all patients to make sure that if there are new brain metastases that do occur, or even in an area that we have previously treated, that they're caught early so they can be managed appropriately.
Okay. And what about management? You listed the side effects during the presentation for radiation. What kind of medication, or how do you manage the side effects such as fatigue or those sort of things? Are there things that help with those side effects?
Yeah, so certainly, sometimes from the delivery of the radiation treatment or from the metastasis themselves, there can be edema that surrounds the metastasis. And so that oftentimes is managed with steroids. So that's kind of one of the primary tools that we use. And then, I mentioned Memantine for some of the memory changes that can occur with whole brain radiation treatment as well too. Oftentimes there's anti-seizure medications that are oftentimes prescribed as well too, as prophylaxis sometimes for potential seizure activity.
Okay, and we are just about out of time. Is there a recommendation for somebody newly diagnosed that either of you would have? Someone who's just been diagnosed with brain mets?
I think, discussion with their provider and their clinician, right? We're a team, so we're all trying to help take care of you, but it is a multidisciplinary team. So just having that trust and conversation. And if you don't know what to expect, ask. If you don't know, if you're afraid, we're here, we're doing this every day. So we probably have most of the answers that come through our patients' heads. So, it is a journey. So it's just, we're along for the ride.
Okay, well, thank you to Dr. Soyano and Dr. Ahmed for a very informative program. And thanks for everybody participating and submitting questions. This has been, a really great hour. I did want to let everyone know that we've been hard at work, very hard at work, creating a website that is going to be dedicated to breast cancer brain metastasis, as well as leptomeningeal disease. It'll be a resource for patients, and it's hopefully will be launched later this year. You'll be able to find it at mbcbrainmets.org. So please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous. So once again, thank you to our speakers and audience. We are grateful for your presentation and attendance today. Bye.
Thank you.
Thank you.